Yeah, no, today we're talking about Chiari, and I know you guys had a nice introduction from Dr. Tomei last week, and so I think some of, I'll try to go over probably some similar material again, just to keep people up to date, and then hopefully we'll talk about some other things that are a little bit more focused on clinical decision making and actual nuts and bolts of doing the surgery for a Chiari. And so, needless to say, I'm happy to be stopped along the way or just look for questions in the chat. And I have a couple of points along the way where I'll stop to look for that. So feel free to ask things along the way. Now, I don't know, can you guys see my mouse moving around or no?
Yes, I can see it.
Okay, perfect. So this is a basic outline of kind of what we'll talk about. I'll deviate from this a little bit, but this is kind of what we got in terms of what you guys were looking for from the talk. So I'll talk a little bit about some general stuff and then kind of go back towards some of the indications with regards to surgical decision making versus watching, and then some of the details around what the different approaches operatively are for Chiari, and also walking through sort of step by step with the operations themselves. So one thing that I just kind of wanted to start with is, even though Hans Chiari described both Chiari 1 and 2, and obviously 3 and 4, which we won't really talk about, and they do have similarities, they're very distinct entities, and certainly the populations in which they occur are really distinct. So while they do have a number of things in common, it's important to sort of recognize how different they really are. And so even though they have very similar sounding names, they're really quite different entities. And just by way of example, which you probably heard last week, Chiari 1, which is going to be much more common, happens with herniation of the cerebellar tonsils, versus 2, which is herniation of the vermis, a more centrally located anatomical structure. And most patients who have Chiari 1 don't have a lot of other associated conditions. So it's not something that's part of a greater syndrome in most cases. And we'll pretty much stick to your more sort of bread and butter stuff in this talk tonight. Whereas Chiari 2 is universally associated with myelomeningocele, and that obviously comes with a host of other signs and symptoms and neurological malformations. The most typical symptoms that you see with a Chiari 1 are, posterior tussive headaches, so headaches that you can bring on with coughing or sneezing, Valsalva maneuvers, laughing, playing, things like that are really focused in the back of the head and neck. Whereas while surgery for Chiari 2 decompression is becoming much less common than it used to be, the things that do lead to people doing it tend to be lower cranial neuropathies and brainstem dysfunction. And while you can have that with Chiari 1, that's not the most common reason why we're doing those surgeries. In both of the conditions, though, you can have syringomyelia, you can have scoliosis. In fact, that's incredibly common in kids with myelomeningocele. But kids with myelomeningocele much more often have hydrocephalus, which you have to think about in the context of managing their Chiari. So it's just important to kind of recognize this. And just in terms of looking at this with imaging, you can see the patient on the left has a Chiari 1, the patient on the right has Chiari 2. And of course, they both have what you'd think about right off the bat, which is herniation of some aspect of the inferior cerebellum, the tonsils in the case of one, vermis in the case of the other, at the foramen magnum and into the cervical canal. However, then you start to see some differences. So while the rest of the brain of the patient with Chiari 1 is pretty normal, the patient with Chiari 2 has a number of other features that you can identify. So there's callosal dysgenesis, there's fusion of the colliculi, so that's that term beaked tectum, that's what that is. You can see that the patient with the Chiari 2 has a low-lying torcular hierophili, and that's very important when you think about if you're doing suboccipital decompression, how much bone are you taking before you potentially can get into structures that are really critical. So that's a really surgically, anatomically relevant feature for these patients. And as many of you are probably already aware, there's a number of other features that you see in the brains of patients with myelomeningocele and Chiari 2 as well. So things like, large fused mass intermedia or interdigitated gyri, things of that nature. And then I'll just sort of briefly mention Chiari 1.5 and Chiari 0 because you'll see them come up. We won't talk about them a lot as individual entities, but the processes of how they're managed are very similar to Chiari 1. So the distinction between Chiari 1 and 1.5 is really the position of the obex. So, with the Chiari 1, it's technically defined by herniation of the cerebellar tonsils by 5 millimeters below Macrae's line, or the line that joins the basion to the opistheon or the foramen magnum. With Chiari 1.5, what you have is actually the positioning of the obex below that line. And so it's kind of a shifting of the brainstem down. And sometimes the term Chiari 5 is blended in with the term complex Chiari. And I think that can be a little bit of a challenge because it's just imprecision in the language. You don't necessarily know what you're talking about. But Chiari 1.5 is defined by that brainstem difference. Chiari 0, in my experience, has been a little bit of a yeti. I don't think I've ever seen a patient with one. I haven't decompressed a patient with one, but the concept behind it is that you actually have Chiari-like physiology in a patient who doesn't have herniation of their tonsils. So you have potentially symptomatic syringomyelia without actual tonsillar herniation, and that can be treated by doing a posterior fossa decompression and opening up potential arachnoid adhesions or something like that that's causing that type of physiology. So now getting back a little bit more to the outline that we had laid out before, the first question was really, how do you make decisions about surveilling a patient versus intervening surgically? And like you'll find with pretty much any medical condition that a physician takes care of, what you're really doing is putting together a puzzle to figure out what the best, what the most accurate diagnosis is and what the most appropriate treatment is. So there's clinical pieces, there are imaging pieces, and there are potentially physiologic testing pieces that you can put together to come to a conclusion around these things. So the classic clinical pieces when you're evaluating a patient for Chiari malformation are headache is number one. So, is the headache occipitally located? Is the headache, as I mentioned before, is it a tussive headache? Is it an inducible headache? Is it an intense headache that comes on really strongly when you cough and then goes away really quickly? So intense, short lasting. Those are sort of your classic textbook headaches that can be treated by surgical decompression of a Chiari if a Chiari is present. When people have migraines headaches, when they have cluster headaches, when they have frontal headaches, those aren't going to get better with treatment of a Chiari, even if they do have a Chiari. So it's really critically important that you hone in and you recognize the details of headaches that can actually be treatable with our therapies for Chiari. Other things that are really common in terms of the clinical findings with patients with Chiari are, neck pain, myelopathy, which that's usually going to come along with a syrinx or something like that. Lower cranial nerve deficit, so that can come along with brainstem compression, and that can manifest as swallowing problems, sleep apnea, snoring, things of that nature. So those are sort of the clinical pieces that you're looking for. Periodically, you'll even see things like eye movement abnormalities or loss of reflexes. When it comes to imaging, obviously MRI scan is going to be the standard. And, as we talked about before, you're looking for 5 millimeters of cerebellar tonsillar herniation, although I'll talk about that in a little more detail in a minute, because increasingly the position of the obex seems to be perhaps correlated more closely with actual symptomatic Chiari. One of the things that we see is there are a lot of people out there who have Chiari malformations by MRI criteria. Many of them are not symptomatic and don't require intervention. So that's one of the big pieces in terms of what we do. When you think about Chiari 2, obviously vermis herniation, do you see a syrinx on an MRI scan? And then do you see scoliosis? And that's really best assessed with just a standard, upright X-ray. So those are sort of the imaging features that you're looking for when you're putting this puzzle together. And then in terms of things like physiologic testing, you can get sleep studies. So it's not uncommon that I get a referral for a patient with a Chiari that's identified because they came in with a sleep problem. They had a sleep study that showed central sleep apnea. That prompted the ear, nose, and throat physician, for example, to get an MRI. Boom, they've got a Chiari and they come over to see me. So those can be really useful adjuncts in terms of diagnosing whether or not someone needs intervention, whether or not they're truly symptomatic. So you say, okay, I've got these puzzle pieces and I'm going to put them together, but how do I know when I put them together whether I should do surgery or recommend surgery or whether I should recommend observation or something else? So I think this sort of conventional wisdom, the way that I was taught and have practiced, is that you can kind of think of it as two buckets of patients. So you have patients who have symptoms and patients who don't have symptoms. So among the ones who have symptoms, what are the symptoms that lead you to say, okay, surgery is the right thing for this patient. I can make this patient's life better by doing surgery. And so if they've got headaches that are really mild, maybe they have them like once every few months and they're not that bothersome, well, do you really want to go through an operation in order to potentially treat that headache? Maybe not. But if you have headaches that are really impacting your quality of life, that are preventing you from doing things you want to do, that may be a circumstance where you do surgery to try to treat those headaches. And that, again, is kind of the most common reason why people present with symptomatic Chiari. And I also mentioned before some of the other symptoms. So myelopathy, if you've got central sleep apnea, things of that nature are clearly symptoms that can be related to the Chiari and that can be either halted or reversed if you do surgery to decompress the Chiari. So those patients very often will merit an operative intervention. Then you have a group of patients who don't have symptoms, and there are still some who benefit from having surgery. So a patient who may have a progressive, albeit asymptomatic scoliosis, that's somebody where if you potentially intervene appropriately, you can prevent them from having a continuing progressive scoliosis, and you may be able to prevent them from needing to have a spine fusion, for example. Similarly, a progressive syrinx, like the patient you see in this picture, she's basically asymptomatic. Over the course of a few years, she's had this progressive syrinx. And is that someone who you think, well, maybe it's time to do a decompression on this patient? And then you get into sort of the risk-benefit ratio associated with the surgery and intervening for something that is asymptomatic at the time. So fortunately, we don't have to just rely on sort of conventional wisdom and teaching and our gestalt about things, because we're increasingly coming up with more objective tools to help. So decision-making aids are really a part of medicine in every field that's out there, and neurosurgery is no exception. And so more and more we're coming up with data to help support our clinical decision-making. And so these are just a couple of examples of papers that have kind of made an effort to do that. So for example, in the Chiari space, people at WashU in St. Louis drive the what's called the Chiari Severity Index. So that's a way to look at the characteristics of the patient, both clinically and radiographically, and figure out, okay, what's the likelihood that someone is going to get better if they have an operative decompression. And in this particular paper on the left, they kind of tried to tie that into something called the Chicago Chiari Outcome Scale and the motor component specifically. And what they showed is actually they don't correlate all that well. So it may be that the CCOS, we can modify it a little bit to improve it and make it better. But the idea that we're trying to come up with sort of objective criteria to serve as decision aids is an important one. Similarly, the paper on the right, I alluded to this one before, that what they found from a large group of patients is that what correlated most closely with a patient being symptomatic and needing to be decompressed wasn't their tonsil position, but in fact, the position of their obic. So they're really looking, largely at Chiari 1.5 patients or patients who have some movement of the brainstem caudally. So it may be that that's actually a much more reliable indicator than tonsillar position. And then that'll come back into the clinic, right? When I'm evaluating a patient or looking at an MRI, I might think about that in terms of someone who's borderline with regard to whether or not we're going to intervene. Similarly, with regard to scoliosis, there's been a lot of good data that has come out recently, and a lot of this, and you'll see throughout the talk that the Park-Reeves Syringomyelia Research Consortium is a 40+ center group that's been around for almost 10 years now, and has gathered both retrospective and increasingly prospective data to try to really dive deep into Chiari management, symptomatology, any aspect of Chiari with syringomyelia that you can think of. So patients who don't have a syrinx don't qualify for this registry and studies that this consortium does. But anyone who does have a syrinx does qualify. And over the last couple of years, it's finally started generating really interesting and important papers that are going to help a lot with decision making with regard to Chiari. So it's a field that's moving along and is very dynamic right now. And some of the best examples of their work thus far are in the scoliosis space. So a couple of papers that they've come out within the last couple of years have basically looked at, okay, well, what characteristics of a syrinx correlate with having scoliosis? So, it turns out if you have a bigger syrinx, if you have what's called a holocord syrinx, so a syrinx that extends throughout the cervical thoracic spinal cord, that really correlates with someone having scoliosis. So having a small syrinx, maybe that's not a big risk factor for scoliosis, but a big syrinx is. Interestingly, the amount of tonsil herniation that a patient has doesn't correlate with scoliosis. And that's something that I think a lot of people had recognized, or at least had an inkling of from their clinical practice. It's very common. We'll see somebody whose tonsillar herniation isn't that impressive, but they have a huge syrinx and a huge scoliosis. And so they were able to generate data that really backed that up. And again, it's another thing that says the actual extent of tonsillar herniation probably isn't the key to what's going on in a lot of these patients. Then turning that into outcome, for me, this is a really important thing, because a lot of the patients that I see get referred through the orthopedic spine program, because I do a lot of spine work. And basically what they found is that in younger patients who have a curve of less than 35 degrees, if you get them decompressed, then that syrinx is more likely to collapse, and that scoliosis is more likely to stabilize than if you have a patient who's older, or if you have a patient with a higher magnitude scoli. And that becomes really clinically relevant in terms of operative decision making, because if I see a 9-year-old kid who's got a 30-degree curve, I'm not going to drag my feet even if they're asymptomatic. If I see a 14-year-old who's got a 40-degree curve, maybe I'll say, look, if I decompress you, I'm not sure it's actually going to help all that much. So that's a different conversation that we're having with that patient than we are with the younger patient. Okay, so we can take this information and we can try to make some clinical decisions with it, right? So we can use this as an example. So this is an MRI scan from a 10-year-old boy who was just up in the mountain skiing, hit a tree, got a CT scan to evaluate him for a concussion. And they said, it looks like there may be a Chiari on there. So he recovered from his concussion. He came back down to Denver, got an MRI scan, and this is the MRI scan. And you can see here, he's got about a 6 or 8 millimeter tonsillar herniation there. No syrinx is visible. And they said, yep, he's got a Chiari. He needs to go see neurosurgery. So he shows up in clinic and you see him, he's got no symptoms, no headache, no neck pain, neurologically normal. He's recovered from his concussion, just wants to go back to skiing and hanging out with his friends. So you say to yourself, okay, this is an incidental Chiari, there's no syrinx. Do I need to operate on this patient or not? So you're putting those puzzle pieces together, right? So with this kid, you may very well say, no, we're just going to watch this kid. But you need to complete the workup. You need a full MRI of the spine to look for a syrinx. So lo and behold, he's got a syrinx. Well, how much does that change your algorithm? So he's got an asymptomatic syrinx now. And for some people, they would say, look, syrinx buys you an operation. Others, maybe not. So you get into a gray area, and that's fine. It's just another piece of data, another piece of the puzzle that you put together. But then let's say we take this exact same MRI scan and we tweak the story a little bit. So now you've got a kid who's got like classic symptoms, right? He's got a year of occipital headaches. They're really sharp. They're intense. They come along when he does sports, and then as soon as he stops, they get better. And from recognizing this pattern, he actually quit his soccer team because he just had so much pain whenever he played, but he doesn't have any neurological deficits. So that's a kid where you'd say, hey, it may very well be that if we do a decompression, we can really help your symptoms and really improve your quality of life. So slightly different puzzle pieces to the story lead to a different recommendation in terms of what kind of therapy this guy needs. One thing I also wanted to mention was the concept of an acquired Chiari malformation. So this is something that looks like a Chiari 1, generally speaking, but is induced by some other kind of condition. It's really important to think about these and recognize these. And the reason I bring it up is because oftentimes when a patient with a Chiari gets referred into CS, they may have just had a spine MRI scan and you don't get a look at their brain. Alternatively, they may just have a brain and you don't get a look at their spine. And it's really important that you get a look at the entire neuroaxis so that you can know for sure that when you diagnose a Chiari, that's what's going on. So things that can commonly lead to what's called an acquired Chiari are hydrocephalus, right? Pushes the cerebellum down, some kind of other space occupying lesion in the brain. Craniosynostosis is a good one. It squeezes from the top. So you'd usually see that in a young baby. A spinal CSF leak, that's a pretty rare reason to have one, certainly a spontaneous occult one, but if you have a history of a known CSF leak, or basically a controlled CSF leak, right, lumboperinneal shunting. So this scan is actually from a kid who we started taking care of last week. He's in the hospital right now. So he comes in, he's got what looks like a Chiari malformation. We scan his head and boom, he's got a big tumor. So the reason he has a Chiari is because of this. So what do? You take care of the tumor. You don't worry about the Chiari. Similarly, kid has hydrocephalus. You take care of the hydro, and then you see if the Chiari is still a problem or not. So it's important to be thinking holistically about these things and to recognize that just because someone has a Chiari doesn't mean that there isn't something that's driving it. So circle back around sort of the idea with the general diagnostic and treatment algorithm. The question you need to ask yourself, and really with anything, with neurosurgery or any other type of surgery, is this patient overall going to benefit from this operation? So with regard to Chiari operations, the series of questions you can ask yourself is, first of all, does the patient have a Chiari? Because a lot of patients come in with a little tonsillar ectopia, so it doesn't meet criteria for a Chiari, or they're not really compressed in the craniocervical junction. So you've got to be sure that they in fact have a Chiari. And if so, is there something else driving it? Do they have an acquired Chiari or do they have a primary Chiari malformation? If the answer to those questions is yes, do they have syrinx? Do they have scoliosis? Because that's going to influence potentially whether you recommend an operation. And if they have symptoms, are they symptoms that are going to get better if you intervene? So like I mentioned before, the frontal headache, the migraine headache, those are not going to get better with a Chiari decompression. So if someone has symptoms, they have to be symptoms that we think we can improve with surgery. Similarly, with other signs, so things like myelopathy, central sleep apnea, are those things that are going to get better. A patient with textbook obstructive sleep apnea, not going to get better with a Chiari decompression. That's something that's going to need, a tonsillectomy or whatever they need. They don't need a Chiari decompression. And then, of course, you always have to ask yourself, is this somebody who is a safe surgical candidate? Do they have some other medical condition that is going to make them high risk? And to what extent does that influence our decision making? So this is one of the points where I kind of wanted to stop and see if anybody had any questions or anything like that. I can actually see the chat. So if any of the panelists want to jump in, are there any questions that anyone has yet?
I don't have any personal questions, but the audience, feel free to type in any questions in the chat. I can pass them along.
Okay, cool. So we'll just move along. So now we've gotten to the point where we're saying, okay, we understand what questions we need to ask in order to decide if we're going to recommend an operation or not. And, we decided, yeah, we're going to recommend an operation. Well, what operation are we going to do? And when it comes to Chiari, there's a whole menu of things you can do. Now, the vast majority of them are variations on a theme because it's a single thing that we're dealing with. But it's important to recognize the pros and cons of all those different options. So they all start, with the exception of the last one, with posterior fossa decompression. And we'll walk through some of those details. But then, do you do a duroplasty or not? Or do you open the dura and expand it? Do you do any kind of intradural exploration? So once the dura is open, do you further explore the craniocervical junction for any reasons? Do you do an OC fusion? So that's something that's becoming less and less common. But sometimes we do have to do that. And those are usually highly complex patients or even patients who are down the road after their initial decompression. And then lastly, I'll talk a little bit about a concept that was kind of controversial a few years ago about recommending C12 fusions for Chiari patients. So this is just like the real basic schematic of what we're trying to do with a posterior fossa decompression. And I think the bone work on this is a little aggressive, but it gets the point across, which is you're trying to, you've got compression that's really happening here at the craniovertebral junction. You can see the tonsils herniating down into the cervical subarachnoid space, compressing the brainstem to some extent. So this is where you're trying to create space. So by doing a C1 laminectomy, by doing a small suboccipital craniectomy, this is much bigger than you normally do. Here they're showing a little bit of a C2 lami. I don't think that's necessary very often. Occasionally, you create additional space here. And then we'll talk about some of the details that come along with that. But that's the sort of nuts and bolts of it. So you say, okay, we know we want to do a posterior fossa decompression. What are the things on the menu that we need to decide if we're going to do or not do? So the first question is really, are we going to open the dura? Because every posterior fossa decompression includes bone removal, C1 laminectomy, but then you can start to deviate. Do you just thin the dura and then you're done? Or do you move on to opening the dura? So there's obviously literature to try to answer some of these questions. The questions are not definitively answered yet, but we're getting more and more data as time goes on. So this is just a couple of examples, one single center study, one meta-analysis. And what they basically found was that if you have a syrinx, the syrinx is more likely to respond more quickly and probably more completely. So it's more likely to resolve or get very small if you open the dura and do a duroplasty. That doesn't mean the symptoms are necessarily going to respond better. It just means the pictures are going to look better. And that's an important distinction. Sometimes that really matters. Sometimes it probably doesn't. And so that's where some of the tougher questions are. So in both of these papers, they basically said, if you've got a syrinx, we'd probably lean towards doing a duroplasty. In the meta-analysis, the paper on the right, what they said is if you don't have a syrinx, we would probably lean towards not doing a duroplasty in order to avoid the risk of CSF leak or other complications that can happen when you open the dura. Because a dura is like a big water balloon, it's under some pressure. You create a weak spot in it by opening it and sewing it shut, and you can have complications as a result of that. The paper on the left, which is from Seattle, found that there weren't really that much in the way of complications, so they didn't worry about it too much. But the meta-analysis from multiple different sites showed that there could be complications, and so those are best avoided if you can avoid them. These are a couple of other papers that look at similar questions. The one on the left is an older meta-analysis, but I think that it did a really nice job, I think, of sort of laying the groundwork for decision-making for a number of years. And what they found was that if you do a duroplasty, you're more likely to solve the patient's symptoms, to solve their problems, so you probably don't need to re-op very often. However, if you don't do the duroplasty, you're less likely to have complications. So that increased rate of solving the problem also comes with basically an equivalently increased rate of complications that can require you to go back in to do something to solve that problem. So it's a little bit of, choose what you want. Do you want to have to go back to operate because the symptoms aren't better, so you got to redo the surgery? Or do you want to have to go back to operate to treat a complication because you have a CSF leak or something around that? And that's really, both of those occurred in somewhere in the like 10 to 12% range. So you really had very similar numbers and you were just sort of deciding which way you wanted to go. And importantly, the clinical improvement of the patients was more or less the same, regardless of which approach you used up front. So there was clearly an issue, and this was early on. There's clearly an issue in terms of defining, well, who's more likely to have a problem if you do a dural opening? So who can you avoid it in? Or who do you really need to take that risk in because they're not going to get better if you don't open the dura? And we really didn't have answers to any of those types of questions when this paper came out. This again was a meta-analysis of the data from 2008. We're starting to get some of that information now. So where some of that information is coming from is Park-Reeves, which I mentioned before. So the paper on the right was basically their initial effort looking to see what correlates with syrinx size. And in that paper, what they basically showed is that that age, and that if you have a duroplasty, you're more likely, again, to have a rapid decrease in the size of your syrinx. That doesn't necessarily mean that you're clinically going to do better. And what they said is we just need to wait for a randomized trial. And lo and behold, they were finishing a randomized trial at the time. So we just finished this study last year, and now we're just doing the follow-up, and then we'll write it up and we'll see what the data show. So we don't have the answer to who is most likely to do okay if you don't open the dura versus who do you need to open the dura for. But those data are hopefully coming along in the next couple of years. I think we have to do 1 year follow-up on each patient before we can analyze the data there. So let's just say you decide, okay, I'm going to open the dura. What do I do after that? Do I just open it and look in there and then sew in my patch? Or do I open it and do some kind of additional maneuvers, so some intradural activity? And historically, there have been a number of things that people have done. They've done things like put a stent from the posterior fossa to the subarachnoid space. They put stents directly into syrinxes. They have tried to plug up the central canal, thinking that syrinx came down from the fourth ventricle into the central canal. People have gotten away from almost all of those things as first-line therapy. We still sometimes will use a stent from the fourth ventricle to the subarachnoid space as like third-line therapy. But one thing that people still do, and I still do fairly routinely, is explore to make sure you see good fluid flow coming across the obex. So what you want to know is that CSF is able to make it from the intraventricular space in the fourth ventricle out into the cervical subarachnoid space and wash back and forth across the foramen magnum. And so all you really need to do in order to verify that is separate the tonsils and look and see. And the reason that this paper is important, this is a paper that came out of Alabama, is they found that in 12% of their kids, when they looked, there was actually a thin veil of arachnoid that was blocking the fluid from getting out. So even if you just opened the dura and sewed it back shut, you still wouldn't have solved the problem in those kids. And interestingly, it was about 10 or 12% of kids who had a dural sparing, right? So that didn't open the dura operation, who failed and had to go back for another surgery. So the question is, are those the kids who correlated with the ones who had arachnoid veils in the fourth ventricle? So you got to open that up and see it and take care of it. And so this is, just my personal opinion is, if you're going to open the dura, look in there, make sure that there's good CSF flow in and out of there so that you've solved that problem. And then if you want, you can heat the tonsils from the outside a little bit and shrink them up to make that space bigger, hopefully to make it less likely that you're going to have some kind of scar formation or something that is going to close that space up again. But that's, again, another choice. So my feeling is, if you're going to open the dura, at least take a look and make sure you've got good fluid flow coming out of there. So you said, okay, we're opening the dura. We're going to make sure there's good fluid flow. Now what are we going to do? We got to close the dura, right? And so generally speaking, people don't do a primary dural closure. They don't just sew the dura back shut again, because the whole object of the surgery is to establish more space there. So you need to try and sew in a patch or something to increase the space. So, okay, I'm going to sew in a patch. Well, what kind of patch am I going to use? Am I just going to like take my shirt and sew it in there? Like, of course not, right? So you got to think about what kind of patch. So you've got broadly two categories. You've got autograft, so the patient's own tissue, and you've got everything else. So allograft. And allograft can come from a number of sources. It can be animal tissue that's been processed. It can be purely synthetic things. So people have looked at success rates using all these different materials to try to figure out what's the best thing to use, because there's obviously pros and cons of anything. So this is another Park-Reeves paper that we just published this year. And basically what it showed is that the total complication rates using either autograft, so a patient's own tissue, most commonly that's pericranium. So you make an additional incision just above your surgical incision and take a piece of pericranium, bring it down, sew it in. So comparing that to using anything else, the overall complication rate was equivalent. However, there was a significant difference in terms of pseudomeningocele, so collection of fluid under the skin, and chemical meningitis. That's basically an inflammatory process where the body has a response to whatever tissue you put in there. So it's not surprising that when you take a patient's own tissue and you just move it around, their body's not going to have a problem with that. But when you bring in something off the shelf that's a total foreign body and you sew it in there, some people's bodies are not going to take too well to that, and they're going to have a big inflammatory response. And it turns out that inflammatory response can be really miserable. It can prolong time in the hospital. It can sometimes require additional surgeries, and it can just make the process kind of awful. So chemical meningitis, pseudomeningoceles, those are things that if you can avoid them, it's definitely worth avoiding. So in my practice, we only use pericranial autograft unless for some reason we can't. And it's largely because of that specific thing. So that was one of the findings of this paper. Then we also took a look at different non-autografts. So there's bovine pericardium, as I mentioned. There's just sort of a collagen graft. And these are different brands, basically, of off-the-shelf grafts. There's purely synthetic things. And what was found there was that the bovine pericardial grafts were actually pretty good. They didn't cause a lot of issues with regard to pseudomeningocele, CSF leaks, chemical meningitis. But when you got into some of those other things, that's really where you started to see those problems happen. So that's really useful because it gives us guidance as to what are we going to put in the patient to create that patch that's going to minimize the risk if they're going to have some kind of complication or difficulty. So this gets into kind of that last thing about what operation you're going to do. So Atul Goel is a very well-known, really well-respected neurosurgeon in India, and he does a lot of complex craniocervical work. He does a lot of upper cervical fusions. And he posited in 2015 that actually all Chiaris are in fact just the body's response to some kind of occult instability at C1, C2. And therefore, every patient with a Chiari should not have a posterior fossa decompression, but instead should have a C12 fusion. So for people who aren't totally familiar with that, that's a great operation when you need it. But first of all, you're fusing two bones together. You decrease range of motion a little bit. You're putting the vertebral arteries at risk. You're putting the spinal cord at risk because you're passing screws right next to them. So in my hands, while that's a great operation, I feel that it's a little bit of higher risk operation than a posterior fossa decompression, and you're taking away somebody's range of motion. So to me, I feel like it's a safer, better long-term option to use a posterior fossa decompression if you can. And there was a very sort of exuberant response from the pediatric neurosurgery community to this concept, basically saying, we don't think this is the case. We do not think it's appropriate to do C12 fusions on every kid who has a Chiari. We think it's unsafe and we're not doing it. So while I thought it was important to mention the fact that there are alternative perspectives and ideas on how to treat Chiari, by and large, the majority of the pediatric neurosurgery community treats them with some form of posterior fossa decompression at this stage of the game. So that's that. So again, I just want to stop here and see if anybody had questions. I think there was one in the chat, right? So let me see what I got here. So this says, did you operate on the stable patient with the syrinx? If no, how long does it take for those patients to begin to show symptoms such as spine deviation. So that's that patient who I showed the picture of with the progressive syrinx, I think is who you're probably asking about. And that patient is going to have surgery, actually. So she is going to have surgery in a few weeks. And I basically had a conversation with her and with her mother and said, this thing has progressed. It's progressed slowly over time. You're doing great. Here are the options. She has a lot of other medical problems. She's this super high flyer 17-year-old kid, but she's got a lot of other medical problems. She said, listen, I want this out of the picture because I got other fish to fry, and I think that we can safely deal with this. So that's the answer to that one. Mona has a question, which is, which body part tissues do you normally take and use in this surgery? Or does it really depend on the patient's health condition? How long does it take for the patient to get recovery from open dural surgery, and any medication they need to take? Sure. So I most typically will use pericranial autograft. So the pericranium is the tissue layer that's investing the outer surface of the bone of the skull. And we take it from about an incision, 3-4 centimeters long, 5 centimeter, or usually about 2 or 3 centimeters above the top of the operative incision, so a separate incision. And we just take that patch out, we sew it in there. Those patients, I typically tell them they're going to be in the hospital for about 4 days after a dural opening operation. Patients who have a Chiari decompression without a dural opening, I usually tell them they're going to be in the hospital somewhere between 2 and 3 days. Many of them actually go home the day after surgery, though. So that's another one of the sort of smaller advantages to the non-dural opening operation is it's just a smaller operation. It's easier for patients to get through that. And so they spend shorter time in the hospital. They have a little bit quicker recovery. Most kids are back in school within 2 weeks or so. Have there been studies comparing different types of dural grafts? So there have not been like head-to-head randomized trials. So that's one of those things that, as you sort of progress through clinical medicine and if you're involved in clinical research, what you'll find is it's hard to get people, especially surgeons, to randomize their patients. Surgeons and even patients have strong feelings about what works and what doesn't work, and to get them to really commit to a randomization process can be a challenge. So registries and things like Park-Reeves Consortium are really great because what they do is they don't randomize, but they have so many patients from so many different places, and it ends up including people who do things all different ways. And then that's sort of a nice proxy. It's not statistically as solid as having a true randomized trial, but you have a very generalizable global experience that you're drawing from. So in Park-Reeves, you had patients, as you guys saw from that paper, who had autograft, who had bovine pericardium, who had other types of allograft. And for the most part, you had a lot of those patients. And so then you can really draw on the experiences of those patients in a generalizable way, right? Because those are real world patients. Randomized trials, like a head-to-head thing, those are really artificial environments. And so they may not represent the general world as well as just a well-done registry. So revision surgery. So the next question is, you mentioned in certain cases get revision surgery. How often does that happen? Generally speaking, if you have a dural opening operation, about 95 out of 100 patients will have a stabilization or improvement of their symptoms. If you do a non-dural opening, it's closer to between 88 and 90. So, roughly 5 to 10% may require revision surgery depending upon the context of what's going on. Okay, so now getting back to sort of the nuts and bolts of what the actual operation involves. So again, here's our schematic. And so the first steps, obviously, with any operation, you got to think, how am I going to position the patient that gives me the safest approach to what's going on? So it will come as no surprise to anybody that for a posterior fossa decompression, the patient needs to be positioned prone. So they're on their stomach facing down in, generally speaking, what's called a Mayfield head holder, which is a pin head holder that keeps their head stable with 3-point fixation. And you can see from the marking here where the incision is going to be. Now, this patient had a non-dural opening operation. If we were doing a dural opening, we wouldn't shave the hair, but we would have a little mark up here where we're going to make the incision to open the dura. So that's where that incision in my practice is. So some people will do them off to the side. Some people will do a crossways incision. There's no standard way to do it. That's what I do. The patient's head is usually flexed. So the idea is if you bring the chin close to the chest, you sort of open up the space down here to separate the dorsal aspects of the bones so that you have more space to do the surgery. So that's a military tuck, is tucking the chin in close to the chest. The external auditory canals are aligned. So you want the patient to be in a neutral position, not rotated with their head one way or another, so that you can have as true an anatomical view as possible. And I almost always use neuromonitoring to monitor spinal cord function during these surgeries. That's not something that everybody necessarily does, but I trained with it and I feel very comfortable with it. And especially because a lot of the patients that I end up seeing, because of how my referral patterns work, do have a big syrinx or neurological deficit. So I want to know what's going on. So the next step is just the exposure. And it's funny because a Chiari decompression is kind of just an exposure and closure for posterior fossa, you name it. So most commonly brain tumors. So in order to get to remove and get out of a brain tumor in the fourth ventricle, you basically need to do a Chiari decompression. So so exposure is kind of a funny term to use because kind of the whole operation is exposure and closure. But you do a midline incision, which you can sort of see by this mark. So it doesn't necessarily have to go from the Indian all the way down to C2, but roughly. The craniectomy that I do is usually about 3 centimeters across, and the height is really determined by where the compression is on a sagittal MRI. So that can vary a little, and you want to be careful not to decompress too much bone because then you can run into a situation where the cerebellum actually starts to hang down and sag a little because it's not supported, and that can be a very difficult to treat situation. So that's roughly what I ballpark for my craniectomies. Universally do a C1 laminectomy. I have not actually done a C2 laminectomy for a standard Chiari 1 operation since I've been in practice. Sometimes people do that. What I find is that you can almost always shrink up the tonsil from behind C2, and then you don't have to do that kind of laminectomy in order to get the operation done. So this is kind of what it looks like in a schematic view once you have the bone off. So what you're seeing here is the cervical dura and the dura at the bottom of the occiput. These are just incision lines. If you're doing a non-dural opening operation, people will often thin the dura. So there are 2 layers of dura. So people will make longitudinal cuts in the outer layer to try to relax it a little bit. There's also always a thick fibrous band right at the craniovertebral junction. So you need to make sure that you come through that. You'll see that in a video in a minute. And that's kind of what that ends up looking like afterwards. And then these schematics are kind of funny, but they're the best that I had. So this is meant to be the dura open, propped open. This is the cervical spinal cord. This is getting up towards the fourth ventricle, and the obex would be somewhere in here. And this is somebody, I think, resecting a tonsil. So we don't really do that anymore. What we'll do is take a bipolar cautery and sort of shrink it down from the outside without violating that peel layer. But this is a monopolar cautery and like a towel clamp or something that somebody's doing that with. And then this shows roughly kind of sewing in the dural patch. So here your tonsil is still herniated down below the level of McRae's line here, below the level of the foramen magnum, but you sew in that patch and that creates that space you need in order to allow CSF flow. So this is a 17-year-old girl who I took care of. She came in with some sensory symptoms in her leg, some headaches, and you can see that she had a Chiari type 1. She did not have a syrinx. I use ultrasound a lot. So these are ultrasound images. You can see the pulsation of the tonsil. So she's facing down, and this is the tip of the tonsil right here, pulsating pretty hard against the back of the cervical spinal cord. So you can see how that's kind of pounding. Now, the top of her head is to the left, bottom to the right. This is our incision. The bone is already off. Here, this is the dura. So we just put in what's called a tenting stitch, where you prop the dura up and then you make an incision. We do a linear incision in the dura. A lot of people do a Y-shaped incision, and that's fine too. You can sort of see multiple layers of the dura, and then you see the CSF start to come out. So we've gone through the arachnoid there, which you don't have to do when you make your initial incision, but that often happens. And then you'll see we use this 45-degree Woodson instrument to protect the neural elements underneath as we move up with our cut. This is that fibrous band I mentioned before. So we're cutting through that. And then you see we advance this up to here. And underneath, you'll see the cerebellar tonsils that are herniated down right here. So then you'll see this open up. We put some tenting stitches to prop the dura open. You see the cerebellum here. This is sped up a little. Her heart rate's not really that fast. And so this is the back of the spinal cord, tonsillar loops of pica. And you'll see when this cottonode comes out of the way, you'll see the emergence of the obex, which is going to be right here. And that's where we want to see that fluid flow. And so right now we're just taking down some arachnoid adhesions to make sure there's some space. That's not an arachnoid veil. That's just sort of normal, natural little adhesions. But there you see that sort of wide open fourth ventricle there. You see a little change in the color tone there. And so now we know there's good flow. We've taken care of the problem. CSF can flow in and out of there. And now we're sewing in that autograft patch. And this is just a specific type of suture. And we'll sew that in so you have a little bit of a buffeting there. And you can see you don't need a ton of space. You just need, a few millimeters really to open it up. And that's what that accomplishes. So kind of transitioning this concept towards Chiari 2, I think there's a couple of important points to make. The first one, really the most important one, and I don't know if Dr. Tomei mentions or not, is Chiari 2 decompression operations are becoming really uncommon. So I think I've done, honestly, like 2 since I've been in practice. Some of my partners have done some more because they have bigger practices of myelomeningocele patients, but it's something that isn't needed all that often anymore. And it may be because we're better at taking care of hydrocephalus. It may be some of the influence of in utero surgery. So kids with myelomeningocele are less likely to have a significant Chiari malformation, but this operation isn't all that common. And I find that there are sort of 2 general populations of Chiari 2 patients who potentially need decompression. One is your infant population, and one is sort of your older kids who develop problems down the road. In the infants, you have sort of 2 patterns, and you need to tease them out to figure out if you think a Chiari decompression is potentially something that might benefit a patient. Now, by and large, these kids are showing lower cranial nerve / brainstem dysfunction, so breathing problems. And so the question with a newborn is, have they ever demonstrated that they can breathe well on their own? Because patients with myelomeningocele can have a very disordered brainstem. The formation of the brainstem is not quite right. And some kids, it's not that they're compressed, it's just that their brainstem isn't formed right. And those kids may never breathe well on their own. So if you're decompressing them for the purpose of helping them breathe, it's not going to work. So if you've got a baby who has never demonstrated that they can breathe well on their own, then that's probably not a great operative candidate. Alternatively, if you have a kid who is sitting there and they're breathing on their own, and yeah, they had a myelomeningocele, and then all of a sudden they started having more and more problems, well, that's somebody who, if you take other things out of the picture, most frequently hydrocephalus, and they're still having that problem, maybe they can benefit from a decompression. But these things are becoming, as I mentioned before, less and less common. So with any patient with a Chiari 2, meaning they have a myelomeningocele, those patients very frequently have hydrocephalus. So you've always got to think about their hydrocephalus, the status of CSF diversion, before you think about potentially decompressing their hindbrain. So again, CSF diversion status in the baby, CSF diversion status in the older patient. Typically, the older patient is somebody who has a CSF shunt. You need to verify that that shunt's working, but they will be somebody who usually either has demonstrated that they breathe fine for years and then they go downhill, or you'll see perhaps they've developed a syrinx that has crept up into the brainstem. So that's called syringobulbia, and that's affecting the lower cranial nerve nuclei. That's affecting their ability to breathe. It may even be affecting their extraocular muscles. So that's somebody where you say, okay, they've got a progressive problem that really does seem to be related to something in the brainstem, and perhaps this could benefit from a decompression. But again, you have to know that their CSF diversion is optimized before you do that. So this particular patient is a patient of mine. He's like the one that I've decompressed. He's 19 at the time, Chiari 2, shunted hydrocephalus, and he started to develop lower cranial nerve problems. So he had 6 nerve palsy. His voice started getting bad. He started having a little more problems breathing. He actually started to have some myelopathy as well. And this picture doesn't show it perfectly, but he developed a syrinx that crept up from his cervical spinal cord up into his brainstem. And it doesn't have to go far because his brainstem is sagging down a little bit here. You know, this is kind of his pons. And so this is somebody where it was like, he's got a progressive problem. I explored his shunt. I knew it was working right, and he was still having problems. So that's the kind of the rare situation where you think, well, maybe decompressing this patient can help. And so here you see, this is where the bone is. So the bone is not where things are tight of the skull. He doesn't need a skull decompression, but he needs a C1 decompression, maybe some C2. And so what you'll notice here that's really different than the last patient, the dura is open now, but look at how hazy and cloudy that arachnoid is. So these operations are difficult because there's just more scarring. It's harder to see what you need to see. It's harder to get where you need to get in terms of verifying that there's good fluid flow. So you'll see here, we have to use a lot of sharp dissection. So we're using scissors, we're using blades to cut through this thick, scarred gliotic arachnoid in order to get down to the spaces that we need to see that there's good fluid flow. So this is a very different operation on this level than what we saw with the last one, where we open the dura and lo and behold, we're just looking at the tonsils that look like a normal anatomical specimen. Here again, we haven't taken any suboccipital bone at all. All we've done is cervical laminectomies because the problem is down low. It's in the upper cervical spine. It's not at the level of the foramen magnum itself. So after kind of teasing through all of this stuff, what you see here is we're starting to get down to some more thin normal arachnoid. And, you know, we popped through and now finally we're seeing some normal CSF and we're able to verify, yeah, there's CSF that is now traveling out of the intracranial space into the spinal subarachnoid space. And we've got that decompressed. And hopefully now he'll be able to have better CSF dynamics and that syringobulbia will resolve. And what you saw in the post-op scan is there was some inflammation there, but that syringobulbia had already started to get better. Things looked more relaxed. You'll notice we didn't take any bone at all here. And on the axial images, this syrinx had started to go down. So again, just kind of talking about the differences between Chiari 1 and 2 with regard specifically to surgical considerations. With Chiari 1s, you're really looking at suboccipital craniectomy in addition to C1 Lami. With 2s, oftentimes you're not doing any bone work of the cranium. It's mostly cervical. You may do some additional Lamis with Chiari 2s. With Chiari 1s, it's pretty rare you have to do a C2 Lami, and even more rare, you have to go lower than that. In both cases, you may be trying to approach syrinx or dealing with scoliosis. In the group of Chiari 2 patients, you often have sort of these two populations, and you have to look at them slightly differently. I didn't mention before, but in the infants, we very rarely open the dura. It's just not necessary. In the older ones, you kind of always do because you've got this really dense, difficult to deal with scoliosis that you got to take care of. And as I mentioned before, we're not decompressing very many Chiari 2 patients these days. So sort of in terms of the outline process, we've kind of gone through these different steps. We've talked about the factors that lead us to intervene or to keep surveilling, what decompression involves and what some of the factors that help us make decisions around what we're going to do are, and then use examples of both Chiari 1 and Chiari 2. And just some of the quick takeaways that I would emphasize, one is Chiari 1 and 2 are very, very different in terms of the patient populations and what you're doing, but they get the same label and they're kind of the same because of this correlation of something herniating through the foramen magnum. And really you make your surgical decisions based upon a correlation of your clinical data with the imaging data that you have to go with it and potentially physiologic data as well. The surgical details, do you open the dura? Do you not open the dura? What patch do you use? Are based on the clinical details. But that's really evolving rapidly, especially with work from groups like Park-Reeves Syringomyelia Consortium. When the rubber meets the road, most Chiari 1 patients do really well. They're healthy people to begin with. They've got a very specific problem, and that's really amenable to surgical intervention. Kids with Chiari 2 may be sick. They may be more complicated, but fortunately, they don't really need decompression all that often. And oftentimes, if you can optimize their CSF diversion, that's all they really need you to do. And so that's about all I've got. Obviously, feel free to reach out to me with any questions that you have down the road. I'm happy to answer Chiari questions or help you out with anything else I can help with.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.